Good evening, everyone. Good evening, good evening, good evening. Welcome in. I am excited to be welcomed by Cayenne Wellness Center. Today, we are addressing some very, very hot topics, and we're talking about mental health and suicide prevention. And I hope that this evening you will hear from me. I'm Heather Avant, and I am a patient advocate working in this space with sickle cell and all things mental health because mental health is such a passion to my heart. And I am joined by Dr. Lori Vick, and we have some great slides and some presentations for you. And hopefully, uh, if you have questions, please put them in the comments if you can access to that. But we really want you to have some takeaways. So hopefully today we'll be able to provide those for you. Thank you for joining us. So let's get started. I'm going to talk to you a little bit about the patient perspective, and Dr. Dick will sum it up with a nice round, uh, uh, view of the medical side of this, right? So I can speak from a patient because I am a patient. So break the silence, right? The emotional toll of sickle cell. Sickle cell is so emotional for all of us, right? Living with sickle cell, I'm telling you, especially around the holidays, we're going into this season, and there can be a sense of loneliness, a sense of grief, of loss. Um, right now, anxiety is at an all-time high for everyone. So, as a warrior, when you're in transition season, it could be even worse. And I know for me as a warrior that this season is really tough. I have had my own personal struggles. I have dealt with depression and anxiety. Just this year, I lost my father, and I know that that has really tilted my world upside down. So, for those of you warriors out there that are struggling, understand that you are not alone. So, what are some of the symptoms that you might be experiencing when feeling depressed? I want to really delve into the emotional symptoms, but also really get into like the behavioral, cognitive, and physical symptoms of dealing with this. And I want you all to understand that none of these are, they're not a bad thing, but a lot of them are your body's way of telling you that something is wrong. And it's okay to really look in and look at yourself to see how you can fix those areas, right? We don't want to stay in a symptom of depression. So persistent sadness, uh, and maybe even some guilt about being sad, about feeling down, or I'm not worthy. I want to remind you that you are worthy. There are behavioral symptoms. Sometimes it's just, I want to be alone. I don't want to be around anyone. And I have no energy to be around. Do you have energy to do the things you love? For me, I love the holidays and I love doing all of the things. My body doesn't always love those things. My body sometimes hates doing the things that I love. My mind is willing, but the body is not. And especially right now when it's a little chillier outside and everything aches and everything's a little sore, and we want so badly to do those things, right? We don't have the energy. That can lead to depression. And the thing is again, you're not alone in that. I have felt that way too. And sometimes difficulty concentrating. So having a hard time concentrating, I know for me, I've experienced that um, even today. I can tell you that I have a big project ahead of me. I've been working on for many months, and sometimes my brain goes, I don't want to do this right now. And I think that we have to take into account that grace. And there are tips and tools that I've used to help with that. And I'll talk about those a little bit later. And then the physical symptoms. Did you know that depression can cause aches and pains? It can hurt. It can cause stress in our necks and shoulders. I don't know how many of you out there have experienced pains from your back or your legs, and not knowing that that stress can really affect that. Depression can affect that. You can get aches and pains from these things. What are some of the barriers to mental health support, right? Because, well, we can address that we may have these issues as warriors and as caregivers and as people who are just around you. What are some of the barriers? And I think that some of the biggest areas that we run into when it comes to sickle cell is stigma. I mean, if I ask the audience out there to raise your hand, is have you dealt with stigma in the ED, with nurses, with doctors? Um, yeah. I can say yes on all accounts. And many even people who are just relationally close to me with who have been around me. And then financial and bias, whether unconscious or conscious bias. So, how do we break the stigma? How do we change our community? I think the biggest question is we're so often talk about the fact that stigma exists. We never talk about how we change. How do we change the stigma in the healthcare system, the sickle cell community, with our friends, and sometimes our family, and the people who live abroad, maybe the people you work with, or the people who are at your church, who you may not consider your friends, but they look at you like you're the sick person in the room. How do we change those thought processes? For me, a lot of it is education. I find that when people are more educated about you as a human being outside of sickle cell, who are you? The fact of it is they're literally thinking, oh, well, they're like my daughter, or they remind me of my sister. I get that all the time. Oh, you remind me of my friend Lori, or you remind me of my friend Tanya. And the crazy thing is by doing that, I'm putting myself in a position to break the stigma because they see me and someone else, which means that they can see my disease in that other person as well, which means is it all that bad? So how do we change their minds about what sickle cell is? Financial inequities. Sickle cell is expensive, y'all. And I don't think that any of us don't know this. Sickle cell costs so much money. And there are a lot of financial inequities around how we deal with just life. And right now, times are harder than they've ever been. Raising a child. I know I have an 8-year-old and ooh, he is costly. Childcare, just needing childcare. Just a couple of weeks ago, I want to say 5 or 6 weeks ago, I had to go to the hospital, and my son had to come with me. And that was the first time he's ever come with me to the hospital. And thankfully, it wasn't anything serious, but I had to go in, and I didn't because I didn't have childcare. And it's hard when you're a warrior to be able to pay because it's like, I don't know how long I'm going to need you. Am I going, if I go to the ED, am I going to need him for 12 hours or am I going to need a sitter for 3 or 4 hours? And on top of that, not only do we have to balance that, we had to balance like, is my kid safe? How do they get to school if I get admitted, what happens? And so there's so many unknowns, and all of those are financial and can be financial and very costly. Transportation, we understand that. Uh, and then out of pocket costs. My medical bills are astronomical, y'all. I'm not going to sit here and lie. The way I pay for my medication and doctor's appointments, it is crazy. And insurance is covering less, and I feel like I'm covering more. And so these things can all drive depression. They can all drive sadness and feeling like you're alone and feeling like no one understands you. But I want you to know today that I see you and I understand you. And then a lack of unbiased care. Oh, y'all, this one's a hard one because we all feel like we're not seen. I know that there are times where I feel unseen, unheard, unloved, unwanted, but that is not true. You are seen, heard, loved, and wanted. And the thing is sometimes people can't get out of their own way to give you the care that you need. So that is when you have to ask for it. And sometimes you're just like, I don't want to ask for it. I don't want to ask for care. I want people to know what I need. I want people to just know. You should know. I think I may have said that to my husband a time or two. Shouldn't you just know? You should just know what I need. And the thing is he doesn't. So sometimes I have to lean into them and also lean into my girlfriends. I have such an amazing group of women who I can lean into when life is not lifing the way I want it to, when it's not going the way I want, or just to vent, because sometimes getting it off your chest makes you feel so much better. But understanding that if they are being biased against you, it is not your fault. It is never your fault. How someone else feels about you is not your fault. And I can control my feelings, even if you are the most. I mean, yeah, there are pretty wretched people out there who hurt my feelings, but let me tell you, I can control me. That's all I can do. I can't control them. And it's understanding that. This is the reminder that mental health is not a straight path. It never has been. Some days we have great days, and some days you may feel amazing, like the world is churning at the most perfect pace. The clouds are not in the sky, the birds are chirping, the bones feel great, the joints feel amazing. I call it a no pain day where you could literally go out in the front yard and do cartwheels. Now, I have not experienced that in some time because I am old and my bones are a little bit more rickety. However, we know that this could happen. So it's like you understand that you can have those great days and then the next day you can barely be able to get out of bed. That happens to us. And that is okay. Because the thing is that's life. Some days you have great days and we want to absorb those great days so that they allow us for overflow on the days when it's really bad and when we're not doing so great. Allowing yourself grace in these hard seasons will allow you to cope. So, when on those dark days and when it's bad, and in the seasons, right? Because sometimes they're not just days, they're not just months, they're seasons of darkness, they're seasons of sadness, seasons of grief, seasons of struggle. How can you cope? You can seek help. That is the first and foremost way we can do is we can cope is to seek help. Our physicians, hematologists, therapists, family members, friends, support groups, however trusted people, right? We don't tell our business to everyone. You shouldn't, but you should have your trusted collective few who you can share with all of the hurt and the harm and the danger and who aren't going to judge you, but who all they want to do is wrap you up in their embrace. And I think that when you're down, those are the times that you really need those people to be around you. You got to cherish the good days. And then self-care. Now, we always think of self-care as going out and going shopping and doing the facials and bubble bath, but do you know that for me, self-care is cleaning? It's it's the aftermath of what happens when I clean. It's a dopamine hit. Um, Going for walks, getting the fresh air in my lungs, sitting outside watching my kid play, dopamine hits. I need those, but my house being clean is the ultimate, right? When my house and my space is clutter free and clean and neat, it allows me to be my most productive self. Um, so self-care can come however it comes for you. I think there are some examples on the screen, but that's not all of them. Some people may go for a drive. I love sitting in my car and going for a drive and just being or listening to an audiobook while I drive. It is no greater feeling. I don't like doing that much now because I live in Dallas and traffic here is something else. But on occasion, a drive will solve a lot of problems. And remembering that we have resources. Therapy is offered by Cayenne Wellness Center at no cost to you for residents of California. This is an amazing thing that I think that if you're in California, you should definitely take into consideration because I would love to go sit and tell some third party about all my things. Because the thing is if they judge you, it's not your problem. But maybe they can give you some tools and tips to work through the judgments. Also, Psychology Today, I have used both Psychology Today and Therapy for Black Girls to find therapists in different stages, great resources. And then trying support groups. There are a few listed here on the page, but understanding that there are many support groups out there who would be willing to walk you in and talk to you and hopefully would offer help and looking for a mentor within these spaces too. Finding someone who can help kind of coach you when things get hard. And remember, I want you to remember this. Don't hurt in silence. I think that a lot of times we shut up and shut down because it's easier than talking about the hardness, the hardships of what we go through. It's easier to not speak about those moments and to really just kind of not deal with it. But remember that you shouldn't hurt in silence. Okay. And if you're really hurting, there is some links over down below you can check. And also please, I ask you to visit the I Believe in Therapy toolkit. Um, there's one on SCDAA's website. Excuse me, I have a frog in my throat. There is one in SCDA's website, and I think that I want you to know that Cayenne Wellness offers, again, therapy at no cost to you. And you can also look into sickle cell medical advocacy. There are resources for us warriors out there. And with each passing year, there are more resources and more people who are really delving into the idea of mental health and how to help us stand up and stand straight. Because this season can be hard. And I know for me, I have been in a season and it has been a really hard year. So, one, you're not alone. Two, do it the best you can. And you're doing the best you can. And three, if you really need to, seek help because I want to meet you one day and shake your hand and hug your neck. And so I want to thank you all for listening to my little talk on the patient perspectives. Now I'm going to bring Dr. Lori Vick up. She is a registered nurse and a doctor, and she's going to talk a little bit about the medical side and how more we can dig into mental health and suicide prevention.
Well, greetings, everyone. Thank you so much, Heather, for sharing that with us. There's so many things that you shared that I thought mean so much to everyone, and it's helpful information for us to all process when we're working with people and we're trying to support them and help them. So your lived experience is so valuable, and I appreciate you. So thank you for sharing your perspective. I am going to share some slides with you. I started doing this because a friend of mine, Pat Corley, shared a story with me about a person that she had worked with who felt that they couldn't go on anymore, and their struggle ended untimely with them taking their life. And I just thought, also I had so that really kind of helped me frame the importance of making sure that we talked about suicide prevention and that we talk about the mental health things that are going on with people, and that they know that, again, as Heather said, you're not alone in this. That we want to be here for you to help you in any way that we can. The other incidents that really got me thinking about the mental health needs of people with sickle cell disease is having a conversation about um, depression, anxiety, suicidality, and those kinds of things. And I had a warrior come up to me and say, this is something that we deal with all the time. We talk about it amongst ourselves, but it's not out there as much as it should be, and we're not doing as much in this space. So anything that I can do to make a difference and to help improve things, I'm going to be about that. So let's go forward. So that's a little bit about me. I've told you a little bit about me already. So this is the fourth year that we've done the We Care mental health and suicide prevention conversation. And I am a professor of nursing at the University of South Carolina. I educate nurses, and one of my primary goals is to help nurses to better be able to take care of people that have sickle cell disease, because we got so minimal education about sickle cell when we were in our programs of nursing. And we know that it needs to be expanded because what happens to your bodies is so profound. So this is a part of my work. So there's this fellow who was the first Surgeon General of the World Health Organization, and his name was Dr. G. Brock Chisholm. And we've heard this saying many times before, but he was really the first person that coined it that I could find in the literature. Without mental health, there can be no true physical health. In other words, unless we have solid mental health, it's so difficult for us to be able to manage our physical health needs. And so this is it's really important. And I share this with you because I think I value that very simple statement. So the first thing I'm going to share with you is some information about depression. So when an individual approaches us about depression, we look at this criteria that was developed many years ago, and it's reanalyzed on a regular basis. This comes from the Diagnostic and Statistical Manual of Mental Health Disorders. And this is the criteria that a provider or a psychiatrist or a physician would use to determine, does this person have some depression? So this is the exact criteria that would be used. And so when we're talking about a person having depression, we talk about them having low mood most of the day and nearly at least 5 days of the week or more. We talk about them experiencing a state of anhedonia where they just feel like there's such a profound sadness that they just feel like they can't function on the day-to-day basis. They may experience weight changes, and that can be weight loss or weight gain, but in children, we see weight loss. I want you to know that depression happens to children and it looks different in children than it does in adults because of their developing brain and some limitations in their capacity to communicate what their needs are and those kinds of things. So if you're working with children or have a child with sickle cell disease, it's, a parent is going to be much more tuned in to what their child's needs are and what is happening with them. But as a professional person, when I engage children, I can tell when I have a child who is experiencing this anhedonic state or possibly a state of depression. Also, your sleep gets involved with this, with excess sleepiness or a lack of sleep, or maybe falling asleep and then waking up and having very minimal sleep, not enough sleep for you to have your body go through the cycles that are necessary for you to have good health. And so, in general, we're saying, somewhere between that 7 to 8+ hours of sleep is what we need for good health. Psychomotor changes, and that means their actual physical ability to be able to move and to function. So what we see is a slowing of your psychomotor, and just saying that they don't have energy, that's what anergia means. So those are things that we would observe and converse with the individual about. And then most importantly, are they having frequent thoughts or recurrent thoughts of death or dying, or thinking about or developing a plan of suicide? Have they ever attempted suicide? So all of those would be factors that would be very concerning. Okay, then the next disorder I'm wanting to discuss with you is anxiety disorder. And this, again, this is criteria for us to determine a diagnosis. And anxiety, we all have anxiety in our lives. Anxiety is a normal part of living, but it becomes problematic or it becomes diagnosable when it's interfering with your day-to-day life. When you have such uncomfortability that you're not able to do the things that you would normally do, like go to work, go to school, live your life, take care of your children, take care of yourself, those kinds of things. When, I had family members that said that they had the worry bug. I can remember hearing my grandmother, having this quote worry bug. But the thing is, it's worrying that becomes so pervasive and so strong that you can't control it. And you're just worrying constantly. These signs and symptoms that you see here, the restlessness, feeling on edge, feeling irritable, you may not notice it, but people in your family might notice it and they might say something to you about it. This overwhelms your system and you may become easily fatigued, therefore even leading more kind of reinforcing that irritability. Having difficulty with concentration, like we all have times in our life where we maybe can't recall something just automatically and you have that feeling like you went blank, whatever, that happens. But when this happens on a more repetitious basis and you're just not able to concentrate, people will talk about a lot of headache, neck tension, and those kinds of things, and again, sleep disturbance here. So again, how significantly this impacts your day-to-day life is really what we look at. It's important when I'm educating nurses to share with them, we need to be tuned into the different levels of anxiety. that individuals are experiencing and that they may experience, to know that it goes from a low level to a very high level, actually, even to the point of it being pain, like panic level. And, so that when a person's in panic, they really can't be functioning on anything else. It's so overwhelming to their system. And so we need to be able to support people no matter where they are in this step, but we need to have awareness of what those different levels are. We also are aware that individuals use defense mechanisms in order to help them cope. Um, Coping is variable for individuals based on what their life experience has been, but there are ways for us to help improve coping. And when Heather was talking about receiving counseling services, and I looked at that picture where the person that was talking to the counselor, their brain was all scrambled up, and I was thinking, yes, part of that counseling role is to help that, to kind of pull that tangled up situation that might be going on in our brain into a more linear, manageable situation. So that's really important. Okay. Then suicidal behavior disorder. So it's pretty straightforward here what I have on the slide. So suicidal behavior is individuals taking actions that could cause their death. And if they have not died from that, it's on us to do some intervention. And I've worked with many patients that were suicidal. As a matter of fact, individuals do not enter into health systems where I might be working on a psych unit, or if I'm working in a safe and secure unit for people in a general hospital environment. They don't usually get into the hospital for other reasons than they're suicidal. And then it's our job and our role and our mission to try to help the individual reframe what their thinking is, to support what was behind all of that thinking, and to help them in any way that we can. And then you see what suicide is, and I know that we're all aware that this is a death caused by an intentional use of force directed at oneself. Oh, sorry, went the wrong way. Okay, so here's some suicide data. This is just kind of too much to believe. 800,000 people die from suicide around the globe, and we're looking at an annual statistic here. It occurs most commonly on Monday, the first day of the week, and usually the first week of the month. More frequently in the morning. More suicides occur after major holidays. And when I first started to study this, I figured it would be around Christmas, but it's not. It's at the New Year. And the reason that it's at the New Year is because individuals that are thinking about ending their lives, we all think of the New Year as a time for us to reset and to start again. And those individuals don't feel like they have anything to start again for. And so they're much more vulnerable at that time. And then this is looking at the United States by numbers per 100,000 people. And you can see that the dark colored states, the darkest colors, have the highest suicide numbers. And also, here's the thing that we need to consider. We can't just go, oh, those states, wow, what's going on there? The reason we would have such high numbers here is because their populations are very high. If we compared Iowa to Texas, it's a no-brainer. There are thousands, if not millions, more people in Texas than there would be in the state of Iowa, for instance, or Montana, right? So that they're going to have more numbers, but just to make you aware. And then this is where they did an age adjustment, suicide deaths by state. And so you can just kind of see again, this is the darker the number, the higher the value. The darker the state, I'm sorry, the higher the value. Here's a slide that just shows you something that I wanted to bring attention to about a change in a 10-year time period. That suicide death rates in a 10-year time period from 2011 to 2021, it was a 58% or I'm sorry, 50, got to check my numbers. Yeah, 58% change African American or Black folks from 2011 to 2021. Even though, we're looking at 5.5 per 100,000 to 8.7, when we think about how big a difference that is significant. And certainly so true for the American Indian or Alaskan Native. They're up 70% more. And it does make one wonder what is going on in their lives that have led to such a drastic and significant change. And then look at the age groups where we see suicidal behavior and suicidality. So we're starting with 12 to 17 and then up to 65. And very often people think that it might be the older people or maybe even the young adult that would have higher suicidal ideation. And you can see here, in fact, 18 to 25 is really the highest. And so the most concerning, so it's that young emerging adult that we really need to focus on. What is going on in their lives? And I mean, when we think about it from a growth and development perspective, we know that that's the time where they're leaving home and they're on their own and they're transitioning into young adulthood. And it's a very stressful time and they need a lot of support. Even though, yes, we know that they're legal age now, that's not all of what's necessary for people to develop and to do well and to thrive. And that's what we want for people that we care about. So this is looking at depression and anxiety prevalence in people with sickle cell disease specifically. There is no database that I have been able to find that speaks to here's the depression prevalence in people with sickle cell disease, here's the anxiety prevalence in people with sickle cell disease. But what I have found is a way for me to evaluate some of that by looking at studies that were done where they used reliable and valid measures in their research studies of people that had sickle cell disease, where they evaluated them for anxiety or they evaluated them for depression. And what I found was that 29 to 50% of the adults self-reported having anxiety and or depression with some type of instrumentation that they were using to evaluate them. Probably more often than not, the PHQ-9, and that's a patient health questionnaire with 9 questions that talks about depression specifically. So suicide is an action taken to end pain, emotional and physical pain. When I think about the sickle cell pain crisis that I've seen patients experience or patients have described to me experiencing, and all of the other physiologic and physical manifestations that happen in your body from sickle cell disease, I know that there must be a great deal of emotional stress and maybe even to the point of anguish that is experienced. I don't see how there could not be. It's just so evident to be trying to live with that. So that's why I say it's very important for us to recognize the emotional pain and the physical pain being interrelated, and that we need to frequently reach out to people that are having these experiences. I think the more profound and problematic the disease process, the more we need to be reaching out and supporting them, because their life is just much more difficult, right? And then helping individuals to find a way to maximize their disease management and to have the best coping skills, and using whatever measure will help them to be able to cope best with their health. So here's some risk factors associated with suicide. If you have had an individual in your family that has attempted or completed ending their lives, that increases the likelihood, if you will, that an individual might use that way to cope themselves. I have known multiple cases of families where one person used suicide as the way to manage their pain, and another person in the family did the same at a later point. So that's a very big thing. This is most problematic in males with a 4 times with it being 4 times more likely. If individuals have sickle cell disease and comorbid depression and higher levels of anxiety or other mental health disorders, that's also an issue. And we know that alcohol and substance use disinhibits individuals. So maybe they are really struggling to cope and they're using alcohol to kind of help manage their coping and to manage their pain. And I've seen this. I've been in nursing for since I was in my 20s, and I'm in my late 60s now. So over the past 40 years, I've observed individuals using different substances in order to help them cope. And sometimes it's to their most significant detriment. So we know that it's disinhibitory and it can cause problems. So, any physical illness that exacerbates the chronic pain or the acute pain, um, we also need to look at individuals that have experienced trauma in their early childhood. We call those ACEs or adverse childhood experiences. And there is an assessment instrument that we use to assess children. Um, I would say that having vaso-occlusive crises is a form of trauma that individuals experience throughout their lifespan. I've watched children that have had different disabilities or different health issues or acute disease exacerbations that kept them in a health system and receiving multiple tests, blood tests, having to have IVs, having to have IV access so that they could have different testing done. And each time that was done to the child, they felt more and more traumatized, and the pain that they experienced as they went along, it didn't get like they were more used to it. No, it was the opposite of that. It meant what I saw happen in children was the experience was much worse. It was more traumatic the more they were into this clinical strategies, this clinical interventions that were causing them to have pain. Putting needles in people's bodies is painful, for Pete's sakes, and we just can't deny that. And the more that the kids experience that, the worse it was for them. And I just, I thought that was an important phenomena for us to have knowledge about. The other thing, social isolation, I think the pandemic, I always put that in, that really showed us plainly how significant being socially isolated can be and how difficult that was for people. Also feeling like you're perceiving that you're a burden to your family, that kind of thing. This is very concerning when I hear people talk about that. And but I can appreciate that they feel that it is real. It's real to them. If it's real to them, it's real to me. And I need to help figure out a way to work with them and to help them negotiate and navigate that. And also individuals that feel that they have no space or no place that they belong. Very, very significant. And we need to support those individuals. There's a thing called Beck's cognitive triad. And this is when individuals relate to you the feelings of hopelessness, helplessness, and no future. They don't see the world, they don't see their own future in the world. And when you have that happening, we definitely need to be working with these individuals to support them. Heather brought up the overwhelming stressors associated with the financial burden of having chronic disease and trying to manage that and have a life. It's so hard. And then the neurobiological situation of having low serotonin, which is a neurotransmitter that's related to depression. There are others, but that's one that's well known. So, warning signs, threats or reference to death or suicide, verbalizing hopelessness, withdrawal, like not participating and doing the things that they had normally done, increasing in substance use, reporting being a burden to others, taking on others' burdens and debts. I've seen an entire family where that happened. One son took on all the debts of their family member before they ended their life, of their other family members. Giving away prized possessions is one of the first things I take note of, especially actually at any age group. I was going to say in younger and younger adults, but I've even seen that in older adults as well. And then cluster behavior or copying behavior, where one person does takes their life and then others follow suit. And also, when you have individuals come into your care, and I mean in a health system, and they're receiving support, and maybe they're on medication therapy, and you see this sudden brightening of their mood. Well, we know that antidepressants do help to elevate and give people more energy and that kind of thing. That is always a concerning time for me, because individuals have the energy to carry out the act of ending their lives, where maybe they were so depressed they couldn't even hardly get out of the chair. And now we have the energy to do it. And if they have such strong intent, that's very concerning. So when I'm thinking about sickle cell disease and I'm thinking about depression, I think about this disorder as being very significant, and one with a lot of pain and a lot of head to toe um, physical challenges in terms of what sickle cell disease is actually doing to your body, to every cell, to every tissue, to every organ system. It is significant. And anything that we can do to modify that impact, we need to be doing. Depression and anxiety, these mood disorders, we can do a great deal to help improve them, because we have much better medications now than we have ever had that can kind of correct some of these very significant neurochemical deficits that happen associated with depression and anxiety. You know, we talk about pain being the hallmark symptom of people living with sickle cell disease. And I had a conversation with somebody about that very recently, where we talked about, since we always lay out pain, it seems like that's the only thing that's talked about. And we need to be talking about a lot of things when we talk about a person living with sickle cell disease. So while we know that this is a fact, I want to hear more about what else is going on with you. Yes, if we don't manage the pain, we're not going to get anywhere else, right? That must be taken care of. But I'm thinking on the day that Heather was talking about doing somersaults, I want to have a conversation with you on that day and see what else is going on that we could be working on to improve your overall quality of life. So this is just some more data about things that I have found, that if people are experiencing depression and sickle cell disease at the same time, they're going to have longer hospital stays. They're, you know, they're just, it's not, they're going to have much more difficulty with disease management. Um, Depression prevalence, and this is all depression prevalence. And the thing that I want you to take away with this slide is 18 to 25 have the highest levels of depression. And this is, again, young adults. And look at the suicide, second leading cause of death in people 15 to 34. Okay, this isn't just individuals with sickle cell disease, just to be clear. This is people across the board. And this is so worrisome at the time where people are supposed to be just kind of taking that ball and running with their life and going forward. This is when things can get to be the most difficult. So we've got to be there to support them. I brought up depression screening. And here's the thing. I think every individual that has a chronic illness like sickle cell disease this is chronic. You're going to have it for your life. They need to have routine screening. And I suspect all of you are receiving that. And if you're not, you need to go someplace where you are, particularly if you feel emotionally that you are having difficulty or that you are struggling. So there are these instruments, the PHQ-9 that I brought up earlier, 9 questions just to get a basic evaluation. This does not tells us where people are in the ballpark of where things could be going on. Also, I had a friend that did a study some years back, and I looked at that study in detail just to examine what was happening with regard to depression in that population that she had worked with. And I found here, as you can see, where the dotted line is, all of the people that are to the right of the dotted line had depression was indicated, and it would have benefited them to have received services, right? And then the other people on the other side, it was not as significant. And this just gives us kind of, this is using the Beck Depression Inventory Fast Screen, another very quick test that can be done in your provider's office, whether that's a nurse practitioner, a physician's assistant, or a medical doctor, to just see where you are. I would ask for this if I were you, if I felt like I needed to address my psychosocial support needs. But I hope we get to a point where providers are, taking the initiative. Let me look at the whole person here. Let me make sure that I have done my due diligence to do a very comprehensive look at what's happening with people in total. Okay, so hope and resilience, protective factors. So think and meditate on what gives you hope and where we find hope. And having these protective factors of hope and resilience help us to manage and get through difficult times. And a lot of people do it in a lot of different ways, right? So sometimes contemplating or meditating on what gives us our purpose in life is helpful. But I just don't want to put people in a box and say, this is the way you have to do it. I think we need to find the ways where we feel we're living our purpose and we're doing what we want to be doing with our lives. We want to give meaning and we want to be able to give back. I know that all of the people I've worked with that have sickle cell disease, I feel like they are constantly giving back. And I'm so grateful for the opportunities I've had to work with folks that have sickle cell disease and that are trying to make a difference and are, doing really important things for their community and for all of us that are in the healthcare provider space or educator space to do better with what we need to be doing. Sometimes religion and spirituality are the ways that people protect themselves. And I say, if that is what works for you, absolutely, I want you to embrace it with your whole heart and to find what is the best thing. Um, think about who are the people who care, who cares for you, who are your family, who are your friends, who are the compassionate souls we meet along the way. I have been so blessed in my life with finding those people at the times when I really needed it, and I didn't even reach out and ask for it. It just appeared there. So grateful to all of the sickle cell warriors that I've had the opportunity to work with, to our allies who work in the space, to activists and advocates like Heather and all the good work that she's doing to make a difference. Again, with regard to support, Cayenne Wellness certainly is an organization that you could reach out to get support, but we know that there's not Cayenne Wellness in every state, unfortunately, but there are multiple areas where an individual can reach out and get support. Find your community-based organizations and partner with those folks there. They're waiting for you to reach out. Also, I know that Heather had this. The National Suicide Hotline is open 24 hours a day. It always seems darkest before the dawn. I know that's an old cliche statement, but it's true. When people feel like they're just at the end and they can't make it any further, please do reach out, call. Call at any time, send people emails, do whatever. No one wants you to end your life because you're at a really tough place at a certain time. This is a book that came out a couple of years ago by Courtney Vance, talking about the title's Invisible Ache, and he talks about his getting therapy and what happened in his family, how this helped him to reclaim his power. And so I just recommend it as a book to kind of be inspirational. With regard to interventions, there are mental health resources that are available in multiple places, in mental health clinics, in the health clinic that you receive your care. So even, so your sickle cell centers, just know that there are people there that can, if they can't take care of the needs, they can refer you to the place where you can get those needs met. If you are an individual who is contemplating suicide, I really want you to reach out to someone to develop a suicide prevention plan. Um, you have time, and let's take advantage of that time to do whatever it takes to help you to be safe. So, as providers, I ask that we work with the patient wherever they are on the health continuum, and it doesn't matter if you're in the best of health or you're in the worst of health. We're here to support you in whatever you need, and I thank you for providing health and hope to people that need it. Thank you very much. Here is my email. Feel free to reach out to me if you have questions, and we certainly will take questions at the end.
Absolutely. Thank you, Dr. Vic, for that was so much information, but I think that there were some really big talking points. And I want to take some questions because I know that there was a couple of questions in the chat. And would you say being told we won't live past a certain age plants seeds of depression or anxiety before we know what it is as children? Wow, I think that that is a very profound question, Noah. Thank you for that. And I'll let Dr. Vic take that because I have my thoughts, but I definitely will let Dr. Vic take that.
Well, I'm so glad that you brought this up. I have talked with so many people that have sickle cell disease, and I have 3 cousins that have sickle cell. That's how I ended up getting into this work. And you know, when I talk with people and I tell them about my cousins who are in their 50s, and these are younger people, right? And when I tell them, "Hey, I have some cousins that are in their 50s now," the oldest cousin, she it's inspiring, and it gives them hope. And I was just like, Absolutely. It's to have somebody tell you you're not going to live to a certain age is just like that is traumatic in and of itself. I'm only going to get to hear what does that put in your brain in terms of how quickly you feel you have to live your life. How do you condense a lifetime into a prescribed time that really they don't know what is going to happen to the individual. They don't know what's going to happen to your body. And while we have general numbers, and I'm just as guilty in terms of providing you with numbers there. These are generalized things. They're not the be all end all. And so, yes, absolutely, that would create and provoke anxiety, if not depression, and be a barrier to an individual fulfilling whatever dreams and aspirations they might have. And I think it's really disadvantageous. I don't know what they thought was the advantage in telling people this. And so that's my question to providers that would ever do such a thing.
Well, I guess how do we change that narrative? Because it still happens today. You know, you still have parents who are saying, "Oh, well, I was told my son or daughter may only live to be, or, to this age or to that age." So how do we change that narrative? And I mean, I think this is just it's an out there question because I don't think that there's any one answer, but we need to think differently to make sure that those conversations aren't happening. But I have a question of my own because as you were speaking, a question came up from me, and it's how do we make sure that doctors and nurses are asking about our mental health and having us do the PHQ-9 test? Because I know for me, uh, I'm like, oh, they're going to write in my chart that I'm depressed or depression is going to be it's like a stigma. It's like, should I do this? Or, I mean, if I answer honestly, or right now I'm not feeling like that, but I may have been feeling like that 3 days ago. So how do we, one, get doctors to really see the patient? Because sometimes I know I go in, I'm a cheerful human by nature. However, I have really dark days. And so it's like they're not seeing me on that day. They're seeing me when I'm all, I have on real clothes. I'm not just I'm not just lounging around in my bathrobe, and I actually, like, brush my hair that day. So how do we get doctors and nurses to really see the patient? Because I know that I've gone in with other patients too, and I've seen the same thing where the day prior they were telling me how the world was ending, and then now, are you? Because you weren't yesterday.
You know, I am kind of guilty myself in this. whenever I go into a doctor's office, what do they say? How are you? And I'm good. I'm great. Why am I in the doctor's office then? Right? So that's one thing. In our mindset, when we go into a doctor's office, I encourage people to be like maybe the week before they're going to see their provider, and if they have a set appointment, start taking notes about things you want to discuss. I think that's number one, a really important thing, because I don't know what happens to my brain when I go in to see somebody, but I literally say, "Oh, I'm good. Yeah, everything's fine. Blah blah. Let's move it on. I don't want to be here." Right?
Yeah.
But the other part now, to really get to the question about how do we get screened, I have been, ever since I've had the ability to speak publicly, because my area of work has been mental health since 1992, I think, at least, right? Um, if not before that. Um, I have been asking providers, because they have the ability, to please consider screening their patients so that they're providing comprehensive or holistic, or however you want to look at this,
Right.
care, and really looking at that whole person. It really hasn't gotten traction until, and I'm not saying because of me, I'm saying because providers are really, mental health has become more important. People are more open about it. We can't say it's not stigmatized. So that's almost like getting double stigmatized, right? You have sickle cell disease, pardon me, and right,
Yeah.
you may have a mental
I
health
mean,
disorder.
yeah.
So yeah, we can't say that there's no stigma, because that's not realistic. We know that there is, but it is becoming less stigmatized, and more people are coming out that are well known, that say, "Hey, I have depression, I have anxiety, I have et cetera, et cetera." And it's okay to say that. How dare us think that what's happening in here, and it is a brain associated issue, that that
Absolutely.
that doesn't have as much value as something happened in the heart or the kidneys or whatever. It just does. It defies logic, and it defies intelligence. And so I simply say, please do this. Now, the best thing that I got to see this past summer was, it is a part of initiatives that have been brought forth by people that are developing practice guidelines. Hallelujah. So I think warriors are going to see, at least once a year, their provider's going to screen them for depression or anxiety. And I'm so grateful to see that it's being incorporated into the practice guidelines. So I'm hoping that people will embrace that. And here's the other thing. I've always said this because I have a friend who's a cardiac specialist and wants nothing to do with mental health, and made that quite clear to me. I said, then please refer your patient. If they're not making eye contact with you, if you notice their affect is flat or blunted, please refer them. You don't have to do it. It's not your thing. I want them to be screened and seen by somebody that it is their thing, because we don't want to lose them, you
Yeah,
know?
and I think that it's easy for a lot of practitioners to say, "Well, I treat the body. I'm not here to treat the mind." And I had a hematologist, and I quote her often because she said this to me very clearly. Heather, it is easier to heal your body than it is your mind, Lord. She's like, she's like, and that's when, I understood more than anything. I've always gone to, thankfully, I've always had the benefit of going to therapy since I was in my early 20s, just my own choice, because I knew I needed it. There were just things that I was not getting over and getting past. And I was like, what is this? Um, but it is hard though, for even for me, as a warrior, an advocate, and someone who goes to therapy, to see that list of like, what is it, all your diagnoses or over the years, and to have depression as one of them, and or anxiety, because but those are real life things that happen and have happened and probably will continue to happen in the future. But the thing is the goal is to address them so that they don't become out of hand and
Mhm,
their own
mhm,
creature.
mhm, mhm. It that really does go right back to the stigma, right? How we have regarded mental health. And
Hmm.
it's really been to everybody's disadvantage to have it be so poorly regarded. When to me, it's one of the most important fundamental and foundational things. When we have, just like Dr. Chisholm said, when you have mental health, then you're going to be able to, have physical health to the extent that you're able to self-care. Sometimes we need help, no matter what that is.
Absolutely. Well, Dr. Vic, I thank you for this robust conversation and I thank you for your presentation. And I'm so happy that I was allowed to present and that Kyan asked us to be here. Thank you all for joining us
Likewise.
this evening. We appreciate your time and we hope that you receive something from this. If you would like to reach out, please do so. We would love to hear from you and to talk to you and lean a shoulder. Have a wonderful evening, everyone. Thank you again.
Thank you so much.